Scientific research is not useful unless that knowledge is translated into practice and implementation. So let's take the example of the issue of colistin resistance that's spreading across the world, including developed and developing countries, and what policy actions are taken in various countries, and especially in a country like India, with very high existing antimicrobial resistance. This is a paper we published last year about the carbapenem resistance Enterobacteriaceae carriage rate in stool samples of healthy Indians living in metropolitan cities. 6% of the healthy Indians are carrying carbapenem resistant bacteria in the gut. And these are the people who haven't received antibiotics or not hospitalized. And there are plenty of publications on colistin resistance in hospitals in India and across the world. This is a paper we published early 2014, and there are multiple publications from India. And the whole world know about the importance of MCR gene in the colistin transmission. And MCR is the most famous colistin resistant gene situated in the plasmid, and that can spread across the bacteria. And one of the main reasons of the colistin resistance is extensive usage of colistin in the poultry as a growth promotional agent. There are more than 30 countries have already reported the presence of colistin resistance in the food bacteria and the MCR1 gene positive and many other MCR gene positive in the food samples, human samples, and environmental samples. There's no Indian data on the presence of colistin resistant bacteria in the food samples, and there is only one or two publications on the presence of MCR1 in food in clinical samples. So though we all know about the colistin resistance in the food across the world, nobody in India had looked for presence of colistin resistant bacteria in food samples, and there are very few publications on the presence of MCR1 in clinical samples. So what we did, we collected more than 100 food samples from the Chennai city, from various food outlets. My team and Dr. Balaji from CMC Velu, his team jointly did the work. And what we found was 46% of the food samples that we collected had colistin resistant bacteria in the food samples. And we are not surprised at all. There are more than 30 countries have already reported the presence of this bacteria in the food samples. And then we did additional work, and we looked for MCR1 gene, and we found MCR1 as expected in E.coli samples. We could not find any MCR1 in Klebsiella. But in my clinical practice and clinicians across the world, the most important bacteria having colistin resistance is Klebsiella. And MCR or its variants is rarely the mechanism of colistin resistance in Klebsiella. So why are we so obsessed with the transmission of MCR gene where it's not common in Klebsiella? And we all thought that the colistin resistance in Klebsiella will not spread fast till 2 years ago when the MCR genes appeared. But again, MCR is not the main cause. So scientists look for the cause of rapid spread of colistin resistance in the hospitals across the world. And what they found was there's something called as insertion sequences that is spreading the colistin resistance from chromosome, because the common mechanism of colistin-resistant Klebsiella is chromosomal, whether MGR or other mechanism, they're all in the chromosome. So it won't spread fast like the MCR that is situated in the plasmid. But still, the presence of insertion sequences transmits the colistin resistance from the chromosome 1 bacteria to other bacteria, and that is the cause, that's the main cause of increase in colistin resistance in Klebsiella that is spreading in hospitals. But what we did was, nobody else had ever looked for the presence of MGRB mutation or the insertion sequences in food Klebsiella. We all know about the importance of MCR1 in food. So what we did sequencing to identify the presence of MGRB mutation in the food Klebsiella and the presence of insertion sequences. What we found was, there are plenty of isolates with MGRB mutations and insertion sequences in the food Klebsiella. And that's really worrying, because these insertion sequences, just like in the clinical Klebsiella samples, in the food Klebsiella, if there are MGRB or the chromosomal mutations and insertion sequences spreading them around, that is a real important source of colistin resistance for the clinical samples. We all, and we all know that colistin resistance is extensive and so common across the world, and now we found in India as well, and the presence of MGRB mutation and insertion sequences. Don't you think that is really worrying, and that could be contributing for the colistin resistance in the hospitals as well? Because MCR1, sincerely, MCR or its variants are not very significant from a clinical perspective. It's Klebsiella. So we have mechanism that can explain the food source, Klebsiella, colistin resistance in Klebsiella, as a potential food source. Recently we published this paper recently, and now we are doing an ongoing study. We started analyzing stool samples of hospitalized patients for carbapenem and colistin resistance. I work in a tertiary care center. Up to 1/3 of the new patients referred to me from other hospitals are carrying carbapenem resistant. This particular cohort, 20% of the new admissions had carbapenem resistant bacteria in the stool, but colistin resistance was almost 50%. When I got the initial data, I was shocked. How can you have 50% colistin resistance and 20% carbapenem resistance in new referral? Then we found that these colistin resistant bacteria are not carbapenem resistant, sensitive to most of the other antibiotics, just like the food colistin resistant bacteria. So this extra 30% of colistin resistant bacteria are the typical phenotypic pattern of the food bacteria. And then we started screening healthy volunteers recently. We just initiated the study, we're finding plenty of healthy community volunteers having colistin resistant bacteria in the gut. That explains, so even those new patients coming to the hospital are coming with colistin resistant bacteria in their gut. That's why I make the argument, is the resistance generated in the hospitals or in the community? And now, if it's only a hypothesis, if these insertion sequences are helping the spread of the colistin resistance from these food colistin bacteria to the already existing carbapenem resistant bacteria, don't you think that will produce pan-drug resistant bacteria? So much of carbapenem resistant in a country like India, and so much of colistin resistant from the food, the ideal environment for mixing of the genes and generation of pan-drug resistance. That's really concerning. So what we did, I'm a technical advisory member of the National Antibiotic Policy. When I have this data, I can't sit quiet. So we knew what the reason is. Extensive colistin usage in the poultry. And there was no publication on the colistin usage, the amount of colistin used in India in the poultry before. We did a Google search and we found there's a website where you can get all the imports coming to my country. Which port is coming from which country. We did a search, we went to the website with the help of people and we did a search. We found the amount of colistin imported to India, and most of that import is from China. And China has banned the colistin usage as a growth promotion already in 2016 after that MCR scare. And India still import and still use colistin as a growth promotional agent. So we communicated with the health ministry. And of course, health ministry needs, because in India, the poultry lobby is so powerful. It's a 60,000 crore, that is $10 billion industry. When politicians, we convince the senior politicians, they communicate with the poultry industry, initial answer was no, we can't stop. And such a powerful industry, the politicians really have to convince the poultry industry that this is so important, we need to ban colistin usage, we can't do otherwise. And finally, we could convince the poultry industry, and we are in the process of banning. We are banning the colistin as a growth promotional agent. That's sure. So having data is not enough. You need to convince policymakers. You need to convince politicians. You need to convince all the stakeholders for policy change. India, I do agree, India was slow in the human world. Still, the National AMR Action Plan is not implemented in India. We prepared the National AMR Action Plan in 2017, but implementation is the responsibility of the state, not Delhi. In Delhi, we prepare the policy. In India, states implement the action plan. And only one state has released a state action plan, still at a very slow pace. None of the other states haven't even prepared an action plan. So I'm sorry to say, in the human world, because of the extremely complex the political system of the country, the states and the political system of the country, the implementation is at a very, very slow pace in the human world. But at least when we could convince the Indian government the importance of banning colistin in the poultry, they really got convinced. You take politicians on your board, they will do what we want. So if a policy is not implemented in the country, don't blame the government, blame yourself. And I will take that blame as a part of that blame. It's a fault of the experts and stakeholders why the policies are not implemented in developing countries. Thank you. Thank you.